Thank you very much for the introduction. It's great to be here. So what my task for the next half an hour is to talk you through the natural history of NAFLD and NASH. These are my disclosures. So this is my talk outline, and I want to stress that NAFLD is a multimorbid disease with outcomes that are not restricted to the liver. I will talk about fibrosis progression, long-term outcomes, and what I would also like to stress in my talk is the current knowledge gaps, because there are many, and as we move forward, we need to clarify. So as most of you know, NAFLD has a quite wide spectrum of disease, starting from steatosis, which in the majority of people is non-progressive. But then some people progress, they get inflammation, they can get fibrosis, and this can progress to cirrhosis and liver cancer. And what has changed dramatically in the last 30 years is the prevalence of obesity, and this is what explains to a quite big extent the current epidemiology of NASH. And you can see that the mean BMI in just 30 years increased by 1.5 to 2 kilograms per square meter. And if we look at the proportion of the population that is classed as obese, I don't have a pointer, but if you look at the upper side of the graph, you can see that in Central Europe it is now more than 20%, and in the States it is close to 30%, and this has changed dramatically. Okay. The prevalence is close to 25%, and what is interesting is that there is an important prevalence even in countries where the caloric intake is not more than 2,000 calories, and this also means that it is not only how much we eat, but what we eat as well, and processed food might play a role. Now, despite the fact that it is a disease which is prevalent in 25% of the population, it is under-recognized. This is the proportion of patients which are coded as having NAFLD in 5 different primary care databases. This is the UK database, and you can see that this is not more than 2.5%. So a disease which is prevalent in 25% of the population is coded in 1 to 3% of the population. And this is a big problem when we're trying to understand what the natural history of the disease is. The consequences, as I alluded, it's not just cirrhosis. These patients are at risk of cardiovascular disease and are also at risk of type 2 diabetes. Now, there is quite a big discussion at the moment. Is NAFLD an independent predictor of cardiovascular disease, or is it just because of the risk factors, and it is nothing more than an indicator? And we don't have the answer to that yet. And what is also important to stress, it is the most common cause of chronic liver disease. So more than 50% of the patients that are referred to our hospital, it is because of abnormal liver tests due to NAFLD. It is the most common cause of secondary care referrals. It is very prevalent, but the majority of people who have NAFLD will not die from liver disease. So it's also very, very important to understand this. And patient selection moving forward is very, very important. There are multiple studies, and we can be fairly certain about this, that cardiovascular disease is the main cause of death in unselected patients with fatty liver. And liver disease is only the third cause of mortality. So this is very important, because even if your patient does not have significant liver disease, he or she needs to be seen or needs to have the metabolic comorbidities addressed. And when we try to interpret the results of the natural history studies, it is important to stress that in most of the cases, this is an incidental diagnosis. And there is an important selection bias if we're looking at the natural history studies. So the patients are not coded properly. We don't know what is out there. Fibrosis is not staged properly in the majority of people. And when we look at the results of the natural history studies, there is a huge bias. We might be over or under estimating the severity. I will start with the histological progression. There are important knowledge gaps here because there are no long-term studies with protocol biopsies. So you start with unselected population at year 0, and then you repeat the biopsy at year 5. There are no such studies. And most studies that report on 2 liver biopsies, the second biopsy is a response to a clinical event. So the clinician is worried because the patient has gained weight, because the liver blood tests become more abnormal. So the patient is having a second biopsy. But as you understand, there is an important selection bias there and overinterpretation of findings. There is only one biopsy, only one study from Hong Kong where they actually submitted the patients to a second biopsy as per protocol. And they had 52 patients. They biopsied at baseline and then at 36 months. It is important that 25% of this population had simple steatosis. And of these patients, a third progressed. Half of them stayed in the same stage, and 25% improved. And this is a consistent signal that we get from patients with fatty liver, and it is very different, for instance, from patients with hepatitis B or with hepatitis C, where if there is no treatment, the patients either stay the same or progress. Here, a significant proportion also improves without treatment. And of course, reduction in BMI and waist circumference was associated with improvement. This is an individual patient meta-analysis, and it included patients from 11 studies, and there were more than 400 patients who had 2 biopsies, but these were not protocol biopsies. So there was a selection bias in this study. Again, there were 150 patients with simple fatty liver and 260 with NASH. And you can see that the results are more or less similar. A third progressed, half remained stable, 25% improved. And what is important is that this is most likely a slowly progressive disease. So for a one-stage progression, it took 14 years for fatty liver and 7 years for NASH. And hypertension was the single factor associated with fibrosis progression. And this is, again, why it is important to address all the metabolic comorbidities of the patient that you have in front of you. If we're looking at long-term outcomes, this study comes from Sweden, and it is indeed the study with the longest follow-up, 229 patients, 26 years of follow-up, all had biopsy at baseline, and you can see that what really makes a difference in terms of liver-related events is the presence of advanced fibrosis. This study comes from it's a multi-center study. The follow-up is just 13 years, but you can see that, again, what is important is the presence of advanced fibrosis rather than the presence of NASH. And increased risk is fibrosis, smoking, type 2 diabetes, and statins were protective. This again is an individual patient meta-analysis, and it shows that the risk of liver-related events increases significantly only once the patient reaches F2 fibrosis stage. It might mean that also these patients might have developed liver-related events if they lived long enough, but maybe it's cardiovascular risk which is more pronounced there, and I will show you data on that. This, again, is from our center. We looked at patients with a baseline liver biopsy, 10-year follow-up, and we found that age, fibrosis, and quantification of fibrosis using collagen could predict long-term outcomes and liver events. You can see that over a period of 10 years, 7% of patients developed decompensating events and 3% liver-related events. If we look at population studies, and this again is GP databases from 5 countries. First of all, out of 19 million adults, only a small minority had a NAFLD code, but you could see that the NAFLD code, and particularly the NASH code, gave a very significant risk of liver-related events. Now, I will go through this slide, but it tries to answer the question if fatty liver is an independent predictor of cardiovascular events. It looks at the risk of myocardial infarction. And if you look at the top panel, if you take unselected patients with NAFLD without adjusting for risk factors, then yes, NAFLD has an increased risk of cardiovascular event. However, if you start adjusting for known risk factors such as smoking, statin use, diabetes, systolic blood pressure, then the signal is lost. And what this probably tells us is that it is the risk factors rather than NAFLD per se, which kind of makes sense. I want now to focus specifically in patients with NASH and advanced fibrosis. So what happens to that particular population once the patient reaches a certain fibrotic stage? And these are data from the phase 2 study of simtuzumab. There were 475 patients selected with advanced fibrosis or cirrhosis. They were followed for 2 years. And you can see that within 2 years, 22% of them progressed to cirrhosis, which is quite a significant percentage. Also, 20% of those with cirrhosis developed liver-related events. Hepatic venous pressure gradient, collagen content, and ELF were associated with progression. So what happens is that once the disease reaches this critical stage, then the progression is accelerated. These are high-risk patients that need our input. This is a very nice study published in Gastroenterology last year. Again, it is patients with F3 and F4 from different countries. And you can see that with patients with F3, there was a significant number of vascular events and non-hepatic cancers. And patients with cirrhosis, the risk was decompensation and HCC. And you can see that moderate alcohol consumption was a risk factor in this group. And this graph proves that point. The first decompensation was much more prevalent in those with cirrhosis, and major vascular events was the main cause of morbidity in those with F3. There are very nice studies that compare the natural history of cirrhosis due to NASH to that of hepatitis C. This is from the States, and you can see that in child QA, NASH has a slower disease progression than hepatitis C. But once this reaches child QB or child QC, then the progression is similar. What I found very interesting in this paper is, again, the cause of death. You can see that of the 29 deaths in the cirrhotic group of NAFLD, 8 were cardiovascular. So even in this group, a quarter of the deaths were cardiovascular. And this is very, very important when we are treating these patients. These patients need to be on statins. They need to have optimal diabetic control. We should not be ignoring these very, very important factors. Again, this is a multi-center study. Higher numbers of cirrhotic patients, and you can see that liver-related mortality in the cirrhotics is higher in hepatitis C, but when we're looking at overall mortality, then the curves are the same, which again proves the point. We can predict liver-related events using simple fibrosis markers. This is again from the United States, 300 patients, 10 years of follow-up. And by using a very simple test, FIB4, you can actually gain very significant prognostic information. You can see that patients with a low FIB4, over a period of 10 years, they do not develop liver-related events. So this is something that everyone can use in his or her practice, not only to select patients, but to get an idea of risk. Just to remind you that the FIB4 consists of age, platelet count, AST, and ALT, and you can calculate it very easily with a smartphone or online calculators. If we're looking at patients with advanced fibrosis or cirrhosis, again, this is from the simtuzumab trial, and you can see that the ELF test can, again, stratify patients according to their risk of decompensation. But ELF is a proprietary test, so it costs money. There is a talk on cancer, but what I want to stress is that you can get liver cancer with NAFLD, and you can get it even in non-cirrhotic patients. It's very important. We are beginning to increasingly realize this. We thought that it was only hepatitis B that gave you cancer in non-cirrhotic livers, but actually it's also NAFLD. This was published over 10 years ago now, but it shows that in non-cirrhotic livers, the cancers tend to be well differentiated and of larger size. And of course, if we look at the attributable risk, this is of course very, very low in non-cirrhotic patients, but present. Now, regression, as I showed you, 20% of patients or 25% of patients with protocol biopsies, they improve, they regress. These are the results from the obeticholic acid trial. I don't want to focus on the efficacy or non-efficacy of obeticholic acid, but actually I want to focus to the placebo group. And this has been consistent in all phase 2 and phase 3 studies that 12% and this percentage can be up to 20% of patients in the placebo groups of these studies, they show an improvement. We are trying to find out why this is happening. Is it part of the disease? Is it sampling variability? Is it something else? And when we look at available data, for instance, this is a study from Cuba, where 293 patients had a diet intervention and were biopsied again after 52 weeks. And you can see that patients who lost 10% of their weight, the disease either, this is fibrosis, so fibrosis either stabilized or even improved. So you can get results with weight loss even in the short term. And these are results with bariatric surgery. Of course, the effect there is more dramatic. You can see that patients lost 12 kilograms of square meter of BMI. But what is quite important is the reduction in the NASH score, but also the significant reduction in fibrosis. You can see that before, for instance, 27% had F0. This is 45% a year after the bariatric surgery. So very, very important data, and very important to insist as much as possible for lifestyle changes in these patients. So in conclusion, fatty liver is currently under-recognized in non-hepatology specialties. The mortality is mainly cardiovascular. Fibrosis is the most important predictor of liver outcomes, and we need algorithms to select and follow up these patients. And there are still important knowledge gaps in disease progression, and we hope that in the next 5 years we will be able to fill them as much as possible. Thank you.